their own respective fields who are extremely talented, and we know Paras Hospital has the best of doctors. First of all, Dr. Mohammad Maqbool Suhail, who is Director Intervention Cardiology, Paras Hospital. He has a vast experience and has worked in institutions like Narayana, and worldwide also he has worked. And he has delivered several talks in international conferences also. Dr. Naeem Firdaus Dar, he is Senior Consultant Pulmonology, Paras Hospital. Dr. Hilal Ahmed Mala, Senior Consultant Nephrology. And Dr. Adil Ashraf, Senior Consultant Gastroenterology, Paras Hospital, Srinagar. Management team from Paras Hospital present here. Mr. Arun Sharma, AGM Marketing, Paras. Mr. Bilal Malik, who is Manager Corporate and COP. Mr. Iqbal Rahmani, Senior Executive Marketing. Senior consultants from District Hospital Kargil, senior consultants from the field, consultant doctors, medical officers, block medical officers, my team of Bakria Healthcare and Research Center Kargil. A very warm greetings to all of you for this evening, where we have gathered for a seminar on multiple topics, multiple super specialty topics. Bakria Healthcare and Research Center, as we all know, doesn't need any introduction. We are working from the last many years, since its inception in 2007. We have been providing exemplary healthcare free of cost, and we have been doing such multi-specialty, super specialty camps regularly. Like this camp we have planned for 2 days, super specialty camps, where the cardiology, pulmonology, nephrology and gastroenterology consultations will be done. And likewise, this kind of super specialty camps we organize regularly, and we do in our activities we do free Sunday OPDs also, multi-specialty OPDs, free of cost we provide to the patients. And we have a free diagnostic center where we provide all diagnostic tests, radiological as well as hematological and biochemistry tests at very minimal cost to all the patients. And if some patient is poor, we provide free also. And we have ambulance services also, which includes a critical care ambulance and 2 other ambulances. And we have done a hepatitis free vaccination also to the whole population of Kargil. We have provided screening with vaccination to the whole population of Kargil. So in this initiative, this is our one installment in this initiative of super specialty camp. So Paras Hospital, we are extremely thankful for the management of Paras Hospital for this collaboration, especially Mr. Arun Sharma, Mr. Bilal Malik and Mr. Iqbal Rahmani, who have been exemplary and who have been instrumental in this collaboration and in making this possible. So Paras Hospital, as we all know, is one such hospital in Srinagar which provides all kinds of treatment from the basic to the most complex. And it is such single hospital in Srinagar where patients will get all the treatments. I mean, any treatment possible which is available in any hospital in India is available in Paras Hospital, Srinagar. So we are extremely thankful for them for coming here with their team of expert doctors for rendering service to our poor patients. So if we go to Paras Hospital to get appointment, it's extremely difficult. They are quite busy, but we are thankful to the doctors who have come here at our doorstep and providing service to our patients at our doorstep, and that too free of cost. Because as we all know, Paras Hospital is the best of quality and best of healthcare, but people say it comes at a cost. But I would like to say that every good thing comes at a cost. As we say, sasta bar bar, mehenga ek bar. So if it is costly, but it is effective and quality healthcare. So the people of Kargil are extremely lucky that the team of doctors have come here to serve them. So without much ado, I'll like to formally begin the program with a presentation of Dr. Mohammad Maqbool Suhail, Director Intervention Cardiology, Paras Hospital, who is going to deliver a talk on complex chip interventions. Dr. Mohammad Maqbool Suhail.
Assalamu alaikum. Good evening, respected seniors, dear colleagues, and friends. I am Dr. Makbul, and I am the Director Interventional Cardiology, Paras Hospital, Srinagar. So today, my talk is about interventions. You see, coronary artery disease is one of the one of the most common disease which is prevalent worldwide. It is one of the most counted as killer disease. So that's why we discuss about this disease, and we should know about this disease, because this disease is usually sometimes, and it causes lethal complications. So coronary artery disease, as we know, basically it's a disease involving the blood vessels supplying to the heart, and so it provides nutrition to the heart. So it is very important, these blood supply to the heart is very important for the pumping. As you know, heart pumps the blood to whole body vital organs. So it is directly related to the blood supply. The cardiac functions, pumping function is directly related to the blood supply to the heart. So it is one of the most common diseases, which is known as atherosclerotic heart disease, one of the most common disease which affects the human being, and causes, if the good thing is that now with the evolution of medical science and technology, initially these diseases were not, there was no definitive treatment, and most of the patients, they used to suffer, and it was like an lethal. Now, by detecting this disease early, we can treat it, and patient can live a long life. So the coronary artery disease, interventions are like, if initially what happened when there was a block in any coronary artery, so initially the only treatment was surgery. So in 1977, the first balloon angioplasty was performed. Initially, the only ballooning, how evolved, it was a non-surgical treatment, where by the nick in the artery from usually femoral artery, we go and put a wire into the coronaries and a balloon and open the lesion without surgery. So this was a major breakthrough in the treatment of coronary artery disease. So after that came the era of stents. Initially, the stents which were used were bare metal stents, non-medicated stents, to open the coronaries, but they had high risk of there was high recurrence and failure. Then came the era of the drug-eluting stents. So drug-eluting stents, they were having less chances of this recurrence and failure. So then came initially the treatment was restricted to the simple cases like a single vessel disease. Like there are three main vessels: right coronary artery, circumflex, and LAD. So initial interventions were done on simple focal lesions. So that is how the initial, but with the evolution in skills and technology, the more and more patients presenting with complex disease, initially they were treated with bypass surgery. But now, because of evolution in the skills of the operator, evolution of the technology, now there is a term which is known as CHIP. It's a complex high risk and interventions. Usually why it is different from other intervention. Usually what happens when there are a lot of vessels, so it's common, like multiple vessels, all three vessels are diseased. So what is the conventional? So doctor says most of the go straight away for the this coronary artery bypass surgery. But now with the evolution in skill and technology, we can do such procedures without surgery, but it requires refined skills, and we require a lot of tools and technology. So why? And there is a large group of the patients where they are not suitable for surgery. If they are unfit, like they are not fit for the surgery. So in these situations, we have to do such interventions, which were initially, it was like it was not done, but with evolution. So what is chip? Chip is like patient factors, clinical factors, and the coronary anatomy factors. So that is, if the complexity, there are criterias in the, like I will, so these are the criterias, like age more than 80, females, prior stroke, prior MI, peripheral arterial disease, ejection fraction, like pumping is less than 30, chronic kidney disease. Then procedure like left main coronary artery, 3 vessel PCI, dual arterial access, where we need, and where we need mechanical support like IABP, ECMO. So, and where there is complex lesions, long length more than 60, and where we need a rotational atherectomy. So these procedures are considered high risk chip interventions, which were initial. So these patients require specialized techniques and tools. So I will present without just a patient. 82 years male who was having hypertension, dyslipidemia, COPD. He had a coronary artery, this acute MI, like before 20 days to 1 month, 8 hours he presented, and angiography was performed outside hospital in a tertiary care. So he had complex disease, all 3 vessels were closed, and he was very symptomatic, having severe symptoms. He was refused to go because, in considering high risk of intervention and lack of the expertise, he was then decided and advised to get only medical management. So he was discharged, but his condition deteriorated. Then he presented to my clinic, and he was like old person, 84, 82 years, and severe anemia, his saturation, COPD, his saturation was low, he was in heart failure, and his EF was very 30%, and severe LV, global LV hypokinesia with the mitral regurgitation, mild renal dysfunction. So it was a really challenging case, because such cases were usually initially not treated by angioplasty. So this is the case, just this is his right coronary, this is right coronary artery. So right coronary artery is almost totally occluded. You can see I opened it, and it's a diffusely, in diffuse spasm, it was totally occluded. So we hooked with the guide and passed through the end. I did it through the radial artery. So this you can see now, there is a lesion in the RCA, balloon dilated with the balloon, and then stent was implanted, 3.528 drug-eluting stent. And now we can see the vessel has fully opened. Initially it was not visible at all. So it is left side angio. His LAD and circumflex, they are more than 90% both side. So we hooked with the catheter, passed the wire through the circumflex. There is balloon dilated circumflex, and then we deployed a stent, 3 into 28 millimeter drug-eluting stent. So finally you can see that it has also fully opened. You can see the distal flow. Then his LAD was tackled, 3rd vessel in the same sitting, and his LAD you can see is tightly diseased. There is a tight disease in LAD also. It's almost 90% here we can see, and the wire was crossed, ballooning was done, and then stent was deployed. This is the stent, balloon. So this is, now you can see fully flowing vessels, and he got good result, and he had a good recovery. Within 2 days we discharged the patient, and he is still on my follow-up. He is doing well. So this is the final result on the left side. So this is another patient. He's only 35 years old. He had MI. His angiography was done. He had severe chest pain. He was referred for CABG. But we know in MI, CABG takes lot of time. But in MI, we have to revascularize early. So MI, the best option always is the intervention, that is PCI. Because we don't want to waste the time to get, because patient to get CABG done, it takes lot of time. We have to assess the patient, it takes time. So in intervention we can do it. So he was referred, but his condition deteriorated. He was referred for CABG. Then he was transferred to my center, and you can see his right coronary is also 90% occluded, and then I opened with the balloon angioplasty, and then stenting was done. You can see here stent, balloons, post dilated, results optimized, and you can see his RC is fully flowing with no residual disease. And then on the left side in the same patient, we can angio only, I can see the left main and circ. Left main is also severely diseased. Left LAD is totally cut off. There is no flow in the LAD. So it's a highly complex case. So where we have to pass the wire through the totally occluded vessel, which using specialized techniques and special wires. So CTO, we call it CTO wire, and it was crossed with the CTO wire. Then special balloons, CTO balloons were used to open the vessel, and these lesions were pre-dilated with the balloon, and now you can see there is LAD is now visible. So we had to put 3 long stents from the distal to mid proximal LAD, and up to the left main vessel, up to the aortosteum of the left main. So this was a highly complex case. So we can see the end result. There is good flow in all the left side vessels with TIMI-3 flow, and here we can see again the result was optimized with further balloons, and there we got excellent flow in all the vessels. So this patient who was sent for CABG referred, but in emergency we had to open the vessels, and he is doing well. He is still in my follow-up, asymptomatic. So other topic is like peripheral arterial disease. Most of the doctors, they usually what have now, peripheral arterial disease is also the number 1 treatment option is intervention, peripheral intervention, which is non-surgical. So most of the still patients go for surgery, but most of these patients can be treated, cured by doing simple angioplasty, which is non-invasive. Because if somebody has aortic iliac disease, so putting graft and long incision from aorta to up to the popliteal, it's a very extensive in old age, and there is lot of risk, mortality is very high. So this is 1-2 cases I will show. Not so you know about disease, peripheral vascular, they presented the claudication of buttocks, thighs, calf, depending on the ankle, and they can cause gangrene, so they are also life threatening. So this is one of the patient I will show. This is an iliac artery. He's a smoker. The smoking is one of the most common cause of. So here we can see in iliac disease is critical. There is a critical proximal common iliac disease. So with the wire and catheter, we cross the lesion, and ballooning was done. And after that, there are specially nitinol self-expanding, having least recoil and high radial strength. So this is we use another technology in I use intravascular imaging. So now we can image the vessels like coronary and the peripheral. Inside, we have an ultrasound probe, which is a 2 mm probe. It goes through the coronary arteries or peripheral arteries. So it gives a like histological section and disease like intima, media, adventitia. So this is initial, there is a tight lesion. Then we did a balloon. This is balloon. This stent self-expand stent is deployed across the lesion. Then balloon dilatation was done, and now you can see the flowing. Now there is no residual disease. Simple angioplasty. Usually such patients I have seen, they are sent for surgery. Extensive surgery avoided by just one prick. No stitches, no scar. So this is the iliac artery which causes claudication of thighs, buttock in this region, and it can cause also other issues like gangrene, threatening limb ischemia. And this there I have shared now the IVUS image. Now we can see that wide open lumen in the IVUS. It is intravascular ultrasonography. So I am also doing cases under I do almost my 60-70% coronary and peripheral cases under intravascular image guidance. The advantage of the image guidance, the results are better. Angiography guided angioplasty result long terms are not that good. But when you do IVUS, the failure recurrence, they are reduced almost by 50-60%. So this is the new, initially angioplasty was not done under such imaging, intravascular imaging, so results were not that good. But with this evolution in technology, IVUS, now we are learning day and day how to optimize our results and make it more stent failure chances become very less now, because this shows whether in angio we see stents are open, but in IVUS they are not. So then we do more aggressive ballooning, we open the stents. So that is the advantage of intravascular imaging. So this is this is another case who had stroke, MI, triple vessel disease, and he had a left subclavian. You can see left subclavian is 90% critical disease. So we did balloon dilatation, and then a self-expanding nitinol stent was deployed across the lesion, and you see now the vessel is flowing with excellent results. So this patient having multiple coronary artery disease was treated with PCI, and the subclavian disease treated with the angioplasty without. So this is the now evolution angioplasty. So it has, initially we had surgical options most of now, but we are now taking more complex cases, more territories. We can like renal artery stenosis we can manage with angioplasty, mesenteric ischemia and cerebral ischemia now we can manage with simple angioplasty. So thanks.
Thank you so much for such an enlightening talk, sir, especially for our physician colleagues. It was very enriching and enlightening. But for the rest of us, for non-medical specialties, it was a bit complex. जैसे कि दिलों के मामले हमेशा पेचीदा हुआ करते, तो it was a bit complex for the other specialties. Now from the heart we'll go to the lungs. So I'd like to invite our next speaker, Dr. Naeem Firdaus Dar, who is Senior Consultant Pulmonology, Paras Hospital, Srinagar.
I thank to the management and the Bakriya administration for providing us a chance to speak to this august gathering here. Before I proceed to my talk, I want to sensitize on few things, and I want to pass my gratitude to Dr. Ghulam Hassan and Vilayat sir, under whom I have done my internship, and as a house physician I was working under them in SMHS hospital long back. So a world is small and we are back in the same scenario, in the same platform. So I have come from a Paras hospital here just to sensitize you people what we are providing over there in pulmonology as a specialty, which is growing as a subspecialty. If we look on to the burden of obstructive airway disease, COPD, asthma, this is a huge burden in the population right now. So to tackle these, I think that will be a great service to the community if you are following on to the GINA and the GOLD guidelines, and you sensitize patients how to use the inhalers properly, and quit smoking programs we have launched over there. So these are the some of the basic things which under these things where you can help the obstructive airway lung disease patients who make a great burden in this subcontinent. Second part which I want to focus on is the interventional pulmonology. In interventional pulmonology at Paras, we are having with us latest bronchoscopies available. We have EBUS, we have radial guided EBUS, we are doing thoracoscopies over there. So what are we doing by these instruments? If we see a lung collapse patient in our ICUs, normally long back we used to use mucolytics and chest physiotherapy to dislodge. Patient was not recovering, patient would go on to the ventilator. But right now we have bronchoscopies available. We just go inside, remove the mucus plug, and patient is back to the normal. We have lesions which may be in the central airway or in the peripheral airway, which makes our approach easy to them, and the diagnosis is within no time diagnosis becomes available to them. Sometimes we are not able to reach the lesion. If we see a lesion on the CT scan which is peripherally located, now we have a radial guided EBUS. Through radial EBUS we reach to these lesions, biopsy them, and the diagnosis is available with them. EBUS we do a mediastinal lymph node biopsy through EBUS guided biopsy, and we use these EBUS guided biopsy for staging in lung cancer. We provide diagnosis where we cannot get it through bronchoscopy, like sarcoidosis. Sometimes we have lymph node TB, which we get diagnosis from these instruments. So I would request to the gathering that once you on CT scans, on X-rays, you find such lesions which need interventions, and if they are not available in your part, so a referral can make things easy for the patient as well as for you. A diagnosis is available at a proper time, and we have very good results after that with the treatment options which are currently available. So why I have chosen this topic for today's gathering? It was my first visit to this part of the state, and while I was thinking yesterday that what should I talk there, so the new tourists who are coming to this part of the area, we are receiving a good number of HAPE patients in our hospital. So I thought, let me deliver a lecture on HAPE. It might be very well known to you, but just I want to go through the slide show.
राइट लेफ्ट आप सुनिए उनकी ब्रोशर
अच्छा ठीक. So high altitude illness. So we are already living at a high altitude, and if we see our part of state, it is just above the sea level, and Kargil definitely is above the Srinagar. And so what is high altitude actually? So anything which is above 1500 meters above the sea level, we consider it as a high altitude. If we see the great mountains and other things where people visit, so why people go to high altitudes? So people visit high altitudes for recreational activities, for religious activities, for spending vacations and sports facilities. So once we I think it's lagging behind by a slide. So these are the various slides which show why we visit to these high altitudes and what happens at these high. Sometimes when people go for religious spiritual things to these high, they actually develop high altitude cerebral edema. But because of the religious things, spiritual things, they feel no, we have attained some spirituality, and they refuse the treatment. And that becomes the matter of life and death for these patients. Worsening starts from there. So symptoms of haze are attributed actually to the attainment of state of trance. So they feel they have achieved the spirituality by moving over there, and hence refuse further interventions. So if you see these great heights, the Mount Kailash, Mount of Tibet, Sri Amarnath cave, and the temple of Kedarnath, they are situated at very high levels, above 3,000 meters from the sea level. What actually happens as we move up, our oxygenation level becomes, it dips down, and this has its effect on our various vasculature. There becomes cerebral vasoconstriction or pulmonary vasoconstriction. When these things develop, vasoconstriction develops, there is exudation of fluid in the lungs, and pulmonary edema develops. At the same time, the same mechanism happens within the cerebral vessels. There is a cerebral edema, and there are various symptoms. Patient manifests with headache, dizziness, letharginess. These are the various symptoms with which the patient presents to us. Then how we have to act under these circumstances? As we all know that either we have to go down the altitude, provide him with the oxygen, and if these things are not available, then there is an artificial hyperbaric oxygen therapy to these patients, or we can use CPAP machines. When all these things are not available, then we have to go on to the medication part, like we use vasodilators, we use nifedipine, we use diuretics, we use steroids. These are the various medical modalities which we use. And before having all these symptoms, there is an acclimatization term which if we have a rapid ascent, if we have a gradual ascent, the effects vary from person to person under these. In acute response, there is accommodation, and in long term, there will be an acclimatization. So the physiological changes are also attributed mainly because of the changes in the partial pressure of the oxygenation, and they have their effects on our various body symptoms. So what are the various high altitude illnesses which we come across? The first one will be acute mountain sickness. The symptoms I already described to you. Then as we go higher, it can result in acute high altitude pulmonary edema. Then there will be cerebral edema, and then there will be high altitude headache and the central sleep apnea. What are the various risk factors? Predisposing factors will be already there within the patients. Some patients may have cardiovascular diseases. Some patients may have pulmonary disease like COPD, bronchial asthma. So these patients, before going to these trips, are to be screened. So we have to, once the tourism department has now developed a cell, when they allow these patients to these heights, they undergo through a screening test. In these screening tests, their previous medical history, previous comorbidities, they are checked, their arterial blood gas analysis, their ECG baseline investigations are being done, and then only a go ahead is nowadays being provided, because otherwise we will have more number of cases who have gone to these heights very rapidly and then develop these symptoms, and at these places we have limited medical facilities then to cater such cases. So in acute mountain sickness, when we move above 2500 meter, 1 to 2 days of ascent, these symptoms develop like headache, persistent lightheadedness, nausea, vomiting, lethargy, poor appetite. So then the symptoms vary as per the system involved. Within the cerebral MC, there will be edema, and accordingly there will be a confusional state, there will be ataxia, there will be tremor, there will be seizure activities in these patients. If we go through the CT images of these patients, you see the effacement of the this area. I have already marked in one of the images. Yeah, here. So again, the high altitude pulmonary edema, I have already given the pathophysiology, how it develops. So if you see the imaging in these patients, there is a perihilar shadowing, and then if you see the CT picture of these patients, there is a dense ground glassing. Sometimes when the history is not clear, we mimic them as pneumonia. So we start treating them as severe pneumonia. But we have seen a dramatic response. So when you give oxygen and CPAP, they improve rapidly, these patients. I will show you a study which was done in SKIMS under Dr. Kaul with 31 patients in that study. So I was already telling you there is a pre-travel evaluation for these patients which is nowadays being conducted. So contraindication to high altitude travel will be the same: advanced COPD, advanced cystic fibrosis, decompensated heart failure, sickle cell anemia, unstable angina. And then the treatment options. When we go on to the treatment, so descent to a lower altitude, supplemental oxygen, portable hyperbaric chambers if available. If the descent is not feasible or the oxygen is not available, then the hyperbaric oxygen therapy. So not recommended. I have boxed it: diuretics, dexamethasone, acetazolamide, in case we don't have above things available with us. If we have above things available with us, so use them. So when it comes the role of pharmacotherapy in these patients, nifedipine as sustained release drug, 30 mg 12 hourly. I have written in the footnote, if descent is not possible, oxygen is not available, hyperbaric is not available, under these circumstances these drugs should be used. We should give first preference to those modalities because they show a rapid improvement. Then the pulmonary vasodilators like phosphodiesterase inhibitors, sildenafil, CPAP has shown a good response in these patients. So high altitude cerebral edema, in these patients first dose of dexamethasone 8 mg can be used, then 4 mg every 6 hourly if descent is not possible. So how to prevent high altitude illness? So gradual ascent is the first thing, and you have to acclimatize yourself. Then there is sometimes in who are with the comorbidities or who have low, moderate to high risk, in those patients we use acetazolamide 125 mg as a sustained release drug. So this is the risk stratification in these patients: low, moderate to high risk. and based on the risk stratification, we have the drugs or the modalities of the treatment available with them. So if you can see at the second box, Dr. Parvez Gold made a study in 2013 for Amarnath Pilgrim Yatras. We had almost 31 patients in this study, which came from different parts of the country, assembled in the Amarnath and for their ascent. So yatris with evidence of high altitude illness who were referred to SCIMS, a total of 31 patients based on the history and application of Lacleuse score. We categorized these patients, and this was the age group, mainly 40 years of age, mostly males with comorbidities, these comorbidities, and most of them were having few underlying comorbidities which were mainly cardiac, and the management which was given to them: oxygen supplementation, pulmonary vasodilators, nifedipine, steroids, and 3 patients were put on mechanical ventilation. The conclusion of the study came that high altitude is uncommon below 2500. Improved awareness of high altitude illness among people traveling to these areas for pilgrimization should have a slow ascent acclimatization. Pre-travel evaluation is mandatory with patients having comorbid illness. Improving facilities provided with hyperbaric oxygen therapy, CPAP therapy, and facilities for mechanical ventilation, and awareness among medical professionals regarding the management of high altitude illness. I close here. Thank you very much for patient listening.
Thank you so much, sir. The topic you have selected was very beneficial for the audience, especially because Ladakh being a live laboratory for such conditions, because in this, especially in this tourist season when people from outside come here, we saw all spectrum of this disease. Now I would like to invite, from the lungs, we'll now jump to the kidneys. I'd like to invite our next speakers, Dr. Hilal Ahmed sir, who is a senior consultant nephrologist in Paras Hospital, Srinagar. He is one of the top nephrologists in the valley. He has completed his super specialty from Yashoda Hospital, Hyderabad, and he has worked as a consultant there before working in Paras Hospital. Dr. Hilal Ahmed.
Ghulam Hassan sir has been my senior in GMC Jammu. Dr. Murtaza has been my batchmate. So it's really great to be here and speak in front of all of you. So before starting my topic, actually I did my super specialization from Hyderabad. I was, before joining my super specialization, I was working in SCIMS nephrology only. So then I was working in Fort Escorts Hospital, Amritsar, for almost 5.5 years, and last year I moved to Paras. And fortunately, we have got a very state-of-art dialysis unit in our hospital, where we are managing both in and outdoor patients. We have almost every modality of dialysis available. We are doing routine intermittent hemodialysis, doing SLED, slow low efficiency dialysis. We are in the pipeline to get the first CRRT in J&K. Actually, SCIMS does have a CRRT machine, but unfortunately they are not using at this time that. But in near future we are going to get a CRRT machine also, and in addition to that we are doing plasmapheresis also wherever it is indicated. And in addition, we have a very robust ICU setup there, where we are doing bedside dialysis also. So coming to this topic, actually this she was a young doctor. Actually she is a young doctor. She was actually working in periphery, and her whole family is are of doctors, also having husband also doctor. So she presented to us a couple of months back. She's actually a known case of obesity, having this sleeve gastrectomy done in skims in 2018. And she is now diabetic she was taking insulin and some oral hypoglycemic drugs. She was taking sitagliptin, metformin and dapagliflozin. In addition, she was taking telmisartan for her hypertension, and she was taking levothyroxine also for hypothyroidism. In addition, she was having some depressive illness and was taking escitalopram for that. So she presented with a very short history. She had actually gone to some family function for a family feast in the evening dinner. So once she came back from that, in the middle of the night, she was complaining. She had 2 bouts of vomiting, and then she had some abdominal pain, and family checked that they checked the sugars, it was coming around 40 milligrams. So they thought it is a hypoglycemia, so they gave some oral thing to eat. And but in the middle of night, particularly in the early part of the next day, around 4 a.m., they again noticed that she is again going into hypoglycemia, sugars were around 50. Then by the morning, once it was almost around 6:30, she was having persistent hypoglycemia, and now she was getting a bit drowsy also. So they went to the local hospital, but then because condition was deteriorating very fast, so her BP was borderline also, and she was referred to our hospital. So when we received her in emergency, she was a bit drowsy, she had a borderline BP, her sugars at that time also was very low. So we tried to resuscitate and take the lab results also. We sent the investigations also. So these were the actually investigations what we got there. So she had some anemia, mild anemia was there, and she had predominantly neutrophilic leukocytosis. So she had initially thrombocytosis also, but later on it settled down. And her LFT otherwise was unremarkable, except for her KFT was borderline of having creatinine of 1.48. This was her ABG actually when she presented to us. It was showing very severe high anion gap metabolic acidosis. In addition, there were very high lactates also. So we did her baseline investigations. We tried to rule out whether she has a diabetic ketoacidosis. Her ketones were absent. Her ultrasound was normal. Her echo X-ray was grossly. Although in X-ray there were some lower zone infiltrates there, but overall it was not very this. So we had because she had presented with abdominal symptoms. She had some vomiting. She had some abdominal pain. So we were thinking whether we are dealing with some abdominal pathology, whether any perforation or some gut ischemia. We are dealing with that. Particularly suspicion was because of the severe lactic acidosis. In spite of that, this patient was not having that severe shock at that time, but she presented with very severe lactic acidosis. So we did a CT there. So it was reported as there was some mild thickening in the this descending colon. Otherwise, the whole abdomen. In addition to we did the angiography also. All arteries in the abdomen were normal except for the descending this colon was a bit thickened. So they had reported as there is an acute likely infective colitis. So patient, we started her on IV fluids and then broad spectrum antibiotics. But she started to deteriorate very fast. She reported to hospital in the 10 in the morning, but at 12 she got intubated because she was not responding to commands. Her sensorium was going down, and she was having very severe refractory shock now. We were giving multiple inotropes. We were giving almost norepinephrine, epinephrine, vasopressin. Even we gave her methylene blue also. We gave steroids, the septic dose of steroids also, but nothing was helping. So her BP was going down. In spite of all these efforts, her mean arterial pressure was remaining around 60 only. So in spite of all these things, her this severe okay. In spite of all these things, her this urine output surprisingly was well maintained. So we are expecting when patient has such a refractory shock, her kidney might go into an acute tubular necrosis or an ischemic ATN, and over time her urine output might go down. But surprisingly, she was maintaining her output during whole this time. Another abnormal finding was that once she got intubated, we had not given any sedation to her. It was just an elective intubation to her. But what we found that she had a fixed dilated pupils that was not reacting to any light. So she was not responding at all to any, neither to any painful stimulus, in spite of not using any sedation prior to this intubation. We had a suspicion of whether, because the events had gone very fast, it was just within 12 hours that she had gone. We had some suspicion whether there is any whether she has taken some toxin, whether there is any poisoning there. These are some this toxicology screens which we do in our hospital. We send urine for that, but everything came negative. So because we were losing her, everything was failing, her ABG was not improving, her hemodynamics were terrible. So we decided to go for dialysis. So keeping her condition in mind that she had a very refractory shock, so conventional dialysis was out of question. We could not have done a conventional dialysis. So ideally speaking, a CRRT would have been a better option in this patient, but because we didn't had CRRT facility at that time available, so we went with this lead. So these are the various ABGs actually during this period. So we can see there, so initial ABG when we started the dialysis, you can see the timing also. It is almost 5 p.m. She had landed up around 10 a.m. in the morning. Up to 5 p.m. we were giving everything for this, but nothing was helping. So we started the dialysis. We had another problem that once we started the dialysis, BP went further down. MAP was around 55, but because there was nothing in any other patient, probably I would have thought to stopping the dialysis, but because we are otherwise losing her also, we continued with the dialysis. First we had plan of dialyzing her for 6 hours, then we continued for 8 hours, then 10 hours, and subsequently around we almost dialyzed her for almost 12 hours. And then this was the ABG actually post dialysis, which there was complete improvement in her this acidotic part. She had this bicarbs which were almost 3 initially, they had normalized. So finally, when we corrected these metabolic parameters, there was a dramatic improvement in the hemodynamics also. In next 6 hours, we stopped all the ionotropic support. She was responding to commands, and in next day only we extubated her. Logistical that these osmolality, serum and urine, we have to send it to Delhi. So it is going to take around 5 to 7 days to get the report. So that thing was not going to help us. So although we were just rushing with the fluids, one good thing was that her sodium all along was normal. She never had those classical hypernatremia features. It was not there. So subsequently, we repeated her. We were doing her ketones on daily basis. We repeated her ketones. So on third day, actually, we found that some ketones are weakly positive in this urine. So we did other things also. We did sigmoidoscopy also, because we had a suspicion that on CT basis. So the findings were almost same. Said it was likely an infective colitis only. So if I summarize it, she was a very young female who was diabetic, well-controlled diabetes, although on multiple medications, hypertension, she had hypothyroidism, and now she landed acutely with some abdominal complaints and then severe refractory shock, and complemented by severe lactic acidosis also, which fortunately got improved with the dialysis only. So there were some unanswered questions that what was the cause of this high anion gap metabolic acidosis? What was the disease which we were dealing with? So why she developed severe polyuria? What was the cause for that? And why were these fixed dilated pupils, and which also got resolved over time? So anything from the gathering, actually it is a long presentation. I want an interactive session, that I think that will be better. Anything from the... Ketoacidosis. Yes, ketoacidosis one possibility. There were some things like she presented with hypoglycemia. We usually in a typical diabetic ketoacidosis, we will not see a patient. There are some criteria for
acute abdominal pain we used to read in MBBS.
Yeah, that's the presentation. That is good. That is presentation there. But the classical diagnostic criteria for the diabetic ketoacidosis, we usually have sugars of around 250. Then there are other parameters also, they will have acidosis also, but definitely this was our first. That is why we were doing ketones every day. So any other intoxication, it was still in our although the toxicology screen what I presented, these are just medications for this. There are n number of other toxicology. It was always in our mind that probably she has consumed it, because the presentation, she had gone for that dawat, Alwazan dawat. If a patient is sick and she has sepsis, why should she go there? So poisoning was a thing which was in our mind. Sir, anything else? So definitely, ma'am, we were thinking about this only, but our first this was that it is not probably a classical decay, it might be an euglycemic decay. Euglycemic decay can present like with sugars. They have usually sugars on the lower side, but not usually hypoglycemias. So this was again a bit against this thing. So why we were thinking about the euglycemic decay was that this patient was on SGLT2 inhibitors. She was taking dapagliflozin. So dapagliflozin is one of the warning signs with dapagliflozin is that patient might develop the euglycemic decay. So there are warning signs for this using in type 1 diabetes still there. In post-transplant settings, there are still, and in those patients who are elderly, who have multiple comorbidities, there are still warning signs for these kind of drugs to be a bit cautious while using these drugs in them. No, this is dapagliflozin, empagliflozin, like those, canagliflozin, those. So second thing was, as we know that one of the precipitating factor for the decay is sepsis. So abdominal sepsis can precipitate it. So the points against was that we don't usually see severe lactic acidosis in these patients. Although she had an associated sepsis also, counts were very high, her procalcitonin was high. So we were thinking about it is a combination of things. She has a severe sepsis also and probably an euglycemic decay also. That could have been explained. And another odd feature was that severe hypoglycemia. We usually don't see, either it is sugars will be normal or patient will have high sugars in decay. Another important second differential was the MALA. So that is metformin associated lactic acidosis. So the point in favor of this was this metformin causes lactic acidosis. So she had lactic acidosis, so we had this thing in mind. So against was that she didn't had any underlying comorbidity. Like we don't see metformin is probably the most commonly used drug in all age groups. But we don't usually, there are some warning signs with respect to the, if patient has already a kidney disease, if patient has an unstable heart failure or an unstable liver disease, in those kind of patients there are some warning, particularly with respect to the kidney. But she didn't had anything. So last was definitely she was having sepsis, probably with the multi-organ dysfunction failure. So other things we were keeping in mind was the acute adrenal insufficiency, because those patients also develop with the abdominal symptoms only. They will have vomiting, they will have this, and then they will go into shock. So until you don't replace it, we had done cortisol also, we had given steroids also, but it was not helping. Although we had kept it a possibility, but a bit lower down. So now last thing was definitely poisoning. Still we were thinking about this. So I will, this is a very long presentation. I will just concentrate on these two important differentials which I had kept. One is the euglycemic decay. So euglycemic decay, as I said, it has slightly different criteria than our classical decay, like in terms of the sugars. So usually sugars are on lower side, they could be normal, but patient will have other features of decay, like patient will have patient will have acidosis there, and urine, there will be ketones in the urine. So in these patients, why we have come, actually this was first detected in around 1970 around. So what they found that actually Dr. Monro was the scientist who actually first introduced this term. So what he found that we probably are missing a lot of diabetic ketoacidosis with respect to if we are putting them in this group of this, their sugar has to be high. So what he found that actually diabetic ketoacidosis, it is more prevalent in the population, particularly in diabetics. And unfortunately, this type of a diabetic ketoacidosis is more severe because you are looking at the other things. You are not giving the actual treatment, which is insulin, which is hydration, which is insulin hydration. You are looking into other factors because you think sugar is normal. Why should a patient have ketoacidosis? So this was now the current, why this euglycemic decay is important in current era is because of now that we have got these wonderful drugs of SGLT2 inhibitors. So SGLT2 inhibitors have indication now everywhere. It is in heart failure, it is in diabetic kidney disease, it is a non-diabetic kidney disease. If a patient has a proteinuria non-diabetic kidney, even if he doesn't have diabetes, we now prescribe them. Any glomerular disease with proteinuria, we prescribe them SGLT2 inhibitors. So now role is coming into the fatty liver disease, you name a thing, now it is coming in everywhere. So now because almost every patient, diabetic patient is on SGLT2 inhibitors, or he will be on SGLT2 inhibitors in near future. So the role of this euglycemic decay has to be kept in mind. One of the important pathophysiological, why should these patients develop decay is that if we look into this picture, so SGLT2 inhibitors actually, it usually potentiates the counterregulatory hormones, and it somehow suppresses the insulin release when, because of its mechanism of action, because it acts predominantly on the kidneys only. So it might sometimes cause dehydration in a patient, because nowadays it has some mild diuretic effect also, because it can cause glycosuria. So with glycosuria, some water also gets removed, so it might worsen dehydration in a patient. And because of this glycosuria, ultimately it might precipitate a diabetic ketoacidosis. So triggers are almost same what we see in a classical decay, whether patient has missed his insulin dose, he has some active infection, he has some there were some vomiting, persistent vomiting, or sometimes patient has some this anorexia, he has not taken food properly. So treatment, as we manage the conventional diabetic ketoacidosis treatment, is almost same. It is just the diagnosis. We have to recognize this problem at the prompt time. So treatment would be again same. We have to hydrate patient well, and insulin is the treatment of choice in this situation. So coming to this second diagnosis is the metformin associated this metabolic acidosis. Metformin probably is used very widely in probably one of the most widely used drugs. So it is a very safe drug. It is a very, very safe drug. So I was just asking one of my endocrinology teachers, so how many patients he has seen of this mala. So when this patient was presented, so his response was, I have seen 2 patients probably. So that is only suspicion that they probably had this mala, and in his whole career of 40 years. So metformin is a very safe drug. But definitely there are some conditions where we should be a bit cautious in them, particularly once patient has renal failure. And more importantly, once patient's GFR goes less than 45. So once 45, we have to cut down the dose to 50%. Up to 30, we can use around 500 milligram. But once it is going less than 30 ml, we should better to avoid this drug in those patients. So second group of drugs, these patients is those patients who are elderly patients. If you can see, this is a case series of these patients who had this metformin associated lactic acidosis. If you see, the major risk factors in them were CKD, or he was an alcoholic, or he had a congestive cardiac failure. And the most striking thing is that they were all elderly patients. Almost 90% of them were more than 70 years of age. So we see usually in elderly patients, they have multiple comorbidities. They usually have cardiac issues, they have diabetes, they already have diabetes. Because of diabetes, they have cardiac issues. Now there might be some diabetic nephropathy also. We should be a bit cautious in using these drugs. So what is the treatment if we have, so predisposing factors again would be if patient has an impaired renal function, and then in these situations we can have these precipitation of this mala. So this is the KDIGO guidelines regarding use of this metformin, as I have already said. So we should check the GFR of the patient and then decide the dose of the metformin accordingly. So ultimately, we have this role of renal replacement therapy in mala. Metformin is a dialysable drug. So if we have a suspicion of that patient might have a diabetic, this metformin associated lactic acidosis, so treatment definitely would be an dialysis at that time, because it will be removed from the body, so effects will be a bit decrease. So there were some other differentials which I have discussed. I will not go into the details of these. So another important thing was that this polyuria, we actually reviewed the literature, what exactly was, why she had this. If you see the urine output on the days of admission, first day it was 1800, second day it was 11 liters, third day it was 7.5 liters, fourth day it was 3. Then it was coming down. So we usually see in post-transplant setting. So once we do the transplant, second day the urine output is like this only. So this was a bit surprise to us. So then we were reviewing the literature. We found that so there is a condition of this transient diabetes, idiopathic diabetes insipidus precipitated by the sepsis. So there have been multiple these papers, although they have been case reports only, that there is an apelin, this molecule which usually causes the supraoptic, it usually mimics the central diabetes insipidus. So we actually then attributed probably it was the same, so we did anything. We didn't give any other medication other than that. We chased the fluids and then it settles on its own. So how should we dialyze these critically sick patients? So is CRRT, that is the continuous renal replacement therapy, better, or is the intermittent renal replacement therapy better? So what there might be some, there are some other specialties there. So I will just give a small brief of this. So we usually dialyze patients around 12 hours per week. That means almost 4 hours per day and 3 times per week. So this is called as intermittent standard dialysis, so which we usually do in our CKD patients. So it has some modifications also. I will not go into those details because those are not available usually. There is another model of continuous dialysis, this intermittent dialysis during nocturnal dialysis. It was widely used in the West, that somebody is working, he gets the machine at his home. In the evening he dialyzes himself, in the morning he goes again to the office, so that he is not a bit hospital bound nahi rehta hai wo. So those therapies are not very common, but these therapies, one is the intermittent dialysis which we routinely do, second is the SLED. SLED is the slow low efficiency dialysis. So what we do in this, what is the difference between a conventional dialysis and the SLED is that we want a small clearance per unit time. In normal conventional dialysis, we are doing high volume dialysis. We keep very high blood flows. We keep very high dialyzed flow because we have to do a specific clearance. At least 65% is considered as an adequate clearance. We want to do that thing in 4 hours. But in this SLED, we don't want, because that will cause a lot of fluid shifts also. That will cause fluid shifts, that will cause solute shifts also. And in a hemodynamically unstable patient, that is not what we want. We don't want that there should be rapid shifts, particularly if a patient with cerebral edema, a neurosurgical patient who needs dialysis but has been done a recent neurosurgical, we don't want there should be a rapid shifting in the fluid and electrolytes. Another group is the post-CABG patients, and then another group is the post these shock patients, or small kids or elderly patients. So in those patients who are sick, what we do is in SLED is that we are doing very low clearance per unit time. We keep very low blood flows, we keep very low dialysate flows. With that, we are actually achieving less clearance per unit time, but we compensate it by increasing the time. We usually do it for 6 hours, 10 hours, or 12 hours. So another modality is this CRRT, continuous renal replacement therapy. Its principle is a bit different than the conventional dialysis. Conventional dialysis is based on the principle of diffusion only. So this is based on the diffusion and convection. So we call it as hemodiafiltration. So in that situation, what we are doing actually, we are doing more less flows, but doing dialysis for 24 hours, sometimes continuing it for 48 hours. So that becomes a bit better with hemodynamically. So in early 90s and early 2000s, so there were a lot of papers came with respect to the benefits of CRRT versus the conventional dialysis or a SLED. But recently there have been multiple meta-analyses which have found that both of them are equally effective. It is just the center-based experience because doing CRRT is a complicated thing. It's a very costly thing. So it is better to you see your own what is available there. So they found that mortality-wise there is not much difference. So SLED is as good as CRRT if you do it properly, because it is done in our setting also. So I think that is the end. It is a bit exhaustive now. Everybody feels tired. So if any some short questions there.
What was the conclusion in this patient? Very much interesting.
So that's what actually there is at this point of time still we believe that these first two parameters, either we had an euglycemic decay, second was which was precipitated by sepsis, second was this metformin associated. So see, other parameters will not improve the way she improved. Like for example, if patient has a sepsis and multi-organ dysfunction, she is not going to deteriorate in hours and improve in hours. It is going to take time. She is going to deteriorate over time and then improve over time. And second thing is, we usually don't see this lactic acidosis, which is basically by the septic shock. It is not improved by the SLED because it usually doesn't improve with SLED, because what we are doing, we are taking blood from the patient, we are doing more that hypotension in the body. So, but it helped in our, so still our belief, this conclusion was probably it was a metformin associated this lactic acidosis, or second it was still an euglycemic decay, because diagnostically there is nothing more left that we could have proved it. It is only the clinical presentation, her recovery, that we have concluded that these might be the poisoning could be still a possibility, although there was nothing in this, and there are majority of poisons are removed by dialysis also, but still the recovery would not have been still, okay, one day she will get intubated and second day she will get extubated.
And how is she now?
Absolutely fine. Normal renal functions going to duty.
We do have a dialysis unit here. We are having three CNS machines, three machines, one for infected and two for conventional normal patients. They are giving for us conventional dialysis. If we want to use that, we have certain, sometimes we place patient in shock or low blood pressure. If we want to give that, should we reduce the flow to say 50 to 100 only on that machine?
So the machine you are talking about, so these are the conventional machines, so they have a fixed settings there. So the hemodynamic instability is because predominantly by the dialysate flow. So dialysate flow, the more dialysate flow you will keep there, so the more diffusion will be there. The more diffusion will be there, so more hemodynamic instability can be there. So what we can do is we reduce the dialysate flow. But the problem with this machine is that it has three settings for this dialysate flow. Either you can keep it 300, you can keep it 500 or 800. So you cannot go less than 300. 300 is the minimum thing. Second is with the blood flow also. So blood flow in this conventional machine usually is 150 ml. You cannot go, sometimes we go with this, but that is usually not effective. You have to keep it at least 150 ml. So this is the limitation of this. But machine, you can use the same machine for SLED. You just have to go, you have to increase the time of this. You have to decrease the blood flow to at least 150 or 180, and you have to decrease the dialysate flow to 300. Below that you cannot do with this machine. We have got another machine that is called as, it's a hybrid machine. Same Fresenius, it is called as 500, which the machine you have, it is 4008S. We have 5008S, that's called as hemodialysis. In that you have that setting, you can go up to dialysate flow of 100. Similarly with this CRRT, you can go dialysate flow very low also and keep blood flow also up to 50 around. That is the benefit of it. With conventional machine you can do the SLED, but this should be the minimum thing you can do.
So blood culture was taken or not regarding this machine?
Yes, sir?
Blood culture.
Blood culture was tried.
So sometimes we get patients with hemorrhagic stroke and goes into acute renal shutdown, and we take the patient with the dialysis. Then the use of the heparin is an issue for us. So how to?
So heparin is a very important in dialysis modality. Actually, we are taking blood from to an extracorporeal circuit. So there will be always risk of thrombosis in them. So the maximum thrombosis can happen in the dialyzer because it has a very small fibers in that, semi-permeable fibers. Although the current dialyzers which we have, it is a semi-synthetic dialyzers there. So it is biocompatible dialyzers. Initially they were not there. So there will be a lot of complement mediated reactions initially. So these dialyzers are biocompatible dialyzers, but still the thrombosis is the biggest risk in this. The problem with this is the more thrombosis in those fibers is the more clearance is going goes down. So they will not be contributing to any clearance, so it will go down. So heparin is very important in dialysis sessions. But as sir said, there are some situations where, for example, we have a post-operative patient who has got operated and we needed to dialyze that patient, or the patient has come with hemorrhagic or a GI bleed sometimes, and you need to dialyze that patient. In that situation, we have to give it heparin free only. The problem how we can prevent is that we have to give saline flushes. We have to keep giving this dialysis technician, actually machine now, it's a very sophisticated machine, but they usually give the alarms for this. There is a lot of pressure inside, so they usually give flushes of saline flushes to keep this a bit clean. But the thrombosis cannot be prevented at all. So you have to, sometimes we have to change the dialyzer during treatment, or sometimes, usually one session of dialysis will suffice, but next time you cannot use that dialyzer without heparin.
So what about this IDH? Sometimes we do get patients with intradialytic hypertension. So what do you suggest under such circumstances?
Intradialytic hypertension is the most common complication post-dialysis. There are some causes for this, like because majority of times we don't give them antihypertensives on the day of dialysis, because fearing that he might develop hypotension, which is a much more bigger complication in a dialysis patient. So usually they skip the medication in the morning. And second thing is, if some patient has taken, majority of them are usually dialysable, some part of it gets removed during the dialysis. So we have to first see whether patient is volume overloaded. This is the most important feature in them. If patient is volume overloaded, he will have hypertension. Not in dialysis only, he will have hypertension at home also. So that is sometimes counterproductive. Like for example, I will give an example. A patient comes with a volume, excess volume of 4 liters. So you have to remove that 4 liters. So body counter-regulatory mechanism will work against that. You are removing that fluid per unit time. The maximum fluid you can remove per hour is around 1200 ml. So if you are remove 400, you are removing per hour around 1 liter. So body will react to that. So there will be counter-regulatory hormones released, because you are removing, this machine almost sucks the fluid from the body. So there will be BP high during the dialysis. So sometimes we usually don't react to this. Now usually if patient has 160, 170, we don't react to that. But more than 180 we should be a bit, because patient is getting heparin also. These patients have multiple vascular complications also. Sometimes they might eye problems, sometimes they might throw some. So we can give medications during the treatment only, during this session only.
In the role of carvedilol, sir. Carvedilol in such situations.
We can use any calcium channel blockers or these beta blockers also. Calcium channel blockers are a bit more effective in them. The issue with these drugs is carvedilol and ACE inhibitors and ARBs. They are less dialysable drugs. So, but usually we don't use these kind of drugs in them. Carvedilol to दे सकते हैं, but not ACE inhibitor usually हम avoid ही करते हैं. But calcium channel blockers, they work very well them in these patients. Thank you. Thank you
So much, sir. The way you have described, it seemed easy how you tackled such a complex situation. We can imagine the complexity and the stressful situation you faced. Facing such a patient, especially in the corporate setup, and that too the patient was a doctor with a family of doctors. So, and you came victorious in this complex situation. Congratulations to you on that. So now this reflects your sir's authority and expertise in his field. Now I would like to invite our next speaker, Dr. Adil Ashraf. About him, I would like to say I personally know him actually in his college days when he was doing his residency. He was called the walking Harrison. He was such an intelligent and knowledgeable doctor. He was called the walking Harrison among us. So Dr. Adil Ashraf.
Sir, for all those exhaustive rounds and all the teachings, ECG, X-rays, ABGs and all that. Really a heartfelt gratitude for that. So, you know, when we talk about gastroenterology, since I myself am more, interested in endoscopy. So now the endoscopy, it has been revolutionized in the past few decades. It has gone from the era of simple that rigid or what we call as fiber optic endoscopies to, robotic endoscopies now. So while we all enjoyed the movie Coolie, there were two things which were happening behind the scenes. One was the grievous hurt which Amitabh had, and another thing was that it exposed actually, the bad health infrastructure vis-a-vis the gastrointestinal endoscopy. So to tackle the GI bleed which Amitabh Bachchan had, Mr. Peter Cotton who is known as the father of modern GI endoscopy, had to be flown along with his GI team unit from all the way from London to Mumbai to perform endoscopy on Amitabh Bachchan. And he explains in some, he usually numbers his tweets. So there's some tweet number 500 something. He explains all his illness in that. So from that thing, you know, when the endoscopy had to be called from London to do an endoscopy, and to now where India has, you know, the largest endoscopy unit of the world, along with Mayo Clinic. And this is the gentleman with Peter Cotton. He's Dr. Nageshwar Reddy. Recently he was awarded, Padma Vibhushan, and he has the largest endoscopy unit in the world along with Mayo Clinic. So I had an opportunity of sharing the unit with him, and this was one of my first publications, the advanced endoscopic procedures for liver disease, and I was quite fortunate to share this publication with Dr. Reddy. So while we talk our setup in our valley, so there are a few things which I'll be talking about. It will be all, interaction and some cases only. So while during my residency in gastroenterology at SKIMS, one thing was that, we're crippled as gastroenterologists was that there was no endoscopic ultrasound. The infrastructure, the expertise and all that, it was not available. Right from benign diseases up to malignant diseases, modern GI units, they don't function without an endoscopic ultrasound. So a few years back, it was all the ultrasounds or the MRCPs and all that which used to diagnose biliary tract diseases. So then this paper from the same unit where I worked. It was published in Gut. It was the EOS versus MRCP to perform ERCP in a patient with intermittent likelihood of cholelocholithiasis. So now they say that even MCI does not recognize, GI training in a unit which doesn't have a endoscopic ultrasound. But we have been a bit unfortunate in our state that we didn't have it. Now favor the centers, especially ours. We have the modern endoscopic ultrasound in our unit. So when we talk of oncology, so this all we can do with endoscopic ultrasound. It's a staging. We're fortunate enough to receive some patients from Sher Kashmir Institute of Medical Sciences for staging usually of esophageal cancers. Then we have tissue samplings, contrast ultrasound. It's not available with us. EUS elastography, it's very important, to differentiate between a chronic pancreatitis forming mass or but it's a malignant mass. Elastography is really very helpful in that. Then we have anti-tumor therapy, that's EUS guided RFA, fiducial markers, tattooing or EUS guided RFA of pancreatic neuroendocrine tumors. Then we have relieving the obstruction, whether it is in the form of biliary obstruction, performing an EUS guided rendezvous procedures, performing EUS guided choledocodidnostomy or a EUS guided hepaticogastrostomy. There's always a tussle between now the endoscopists and the gastroenterologists and the surgeons, that many of these things were tackled by the surgeons, and now because of usually these patients will be very sick, stage 3, stage 4 malignancies with the biliary obstructions. So all these things, they are now managed endoscopically. And then when we talk of malignancies, we have the palliative care that's in the form of celiac plexus neurolysis that's also performed by this. This is one of the patients. He had been managed as a GI bleed at a tertiary care center. He had large fundal varices. He had bled multiple times. However, endoscopic glue was not given. Reason was that he had a large gastrorenal shunt. So once there is a large gastrorenal shunt, there is a very high possibility of embolization of the glue. So in all modern units, what we do is that we go for EUS guided glue and embolization of fundal varices. So this is the EUS picture of this patient. These all, this red and blue zone, this is the high flow varices. These are the fundal varices on an endoscopic ultrasound. So what we do is that this is the first case of EUS guided glue, fundal glue varices in our region. So we puncture it transesophageally. We go into the this is the needle there. We go into the varix. We inject coils. So after injection of coils, you can see the reduction in the flow in these varices. And then once we are done with injecting the coils, we inject glue. And here you can see there's complete absence of the flow in these varices. So this is the final endoscopic picture of this patient. You can see these varices which were bleeding. They are all solidified and opacified. So I won't go into this, the complete video. If we get time, we'll discuss about this. Then this, again, a very common thing in our valley, lot of chronic pancreatitis, acute pancreatitis patients. And as a resident in Sher Kashmir Institute of Medical Sciences, we used to always, these patients was always, toggle between the interventional radiologist, placing multiple pigtails, then those pigtails forming this. So this was the case. So she had a middle-aged female, she had a necrotizing pancreatitis, she had a large collection, which was 7.5 into 9 centimeter with a well-formed wall. So this is the US guided image. So this is a large pseudocyst. We are all, you can see there is that needle, we are puncturing the, it's a hot aqueous stent actually. So we puncture it. I'll try to forward it if I get it, yeah. So see, there we're puncturing the cyst through the gastric wall. It's all under endoscopic guidance. Patient is on a minimal sedation, propofol sedation. So this is the flange which is opening. You can point it out there. This flange is opening. We then pull it, approximate it with the gastric wall. So now we switch over to the endoscopic vision. So it's on the posterior wall of the stomach. There is this large collection, a large pseudocyst. We pull it back and you can see the stent opening. This is the proximal flange of the stent. It will just open and you can see all this fluid gushing out from the cyst into the stomach. The procedure takes some 3 to 5 minutes. Patient is on sedation, major surgeries, percutaneous drains and all that, that's avoided. So no complication and patient is discharged. And while we talk of malignancies, this is one of the patient, he had been seen by multiple physicians. So biopsy was advised, but the patients were, very hesitant about they were advised percutaneous because it's all, percutaneous only is done in our state. So patient came to us, so we did an endoscopic ultrasound. There you can find a heterogeneous mass lesion in the pancreatic head. And FNA was done. This is the needle into the mass. So this is the sample tissue. You can see these red bits. And we do a ROSE in our unit. That's a rapid on-site evaluation. The pathologist is basically in the same room at the same time. He gets the tissue, and these you can see the poorly cohesive cells suggestive of an adenocarcinoma. So then this was one of our medico's mother. So endoscopy was done elsewhere. It was showing some mild bulge in antrum. CT scan were repeated thrice at 3 places. They were all normal. So for this bulge, we did an endoscopic ultrasound. And if you can see, I don't have a pointer over here. There's a small lesion. There. Yeah. So there's a small lesion over there. We did sampling of it. Initially, I in fact thought that it's probably a leiomyoma. We did a FNA, US guided FNA, endo ultrasound guided FNA. It turned out to be a neuroendocrine tumor, and we just applied an endoscopic band over it, and the lesion was cured. Moving from endoscopic ultrasound, now we have, the endoscopic management of malignancies. It has been revolutionized since the use of, artificial intelligence and the use of different gadgets. So this is a tumor. Actually a large polyploidal growth. The biopsy was a moderately differentiated adenocarcinoma. She had come basically to our surgical oncology unit. So we gave a choice of a endoscopic resection. So this was the resection, we are using an endoscopic knife. We lifted the lesion, and by using this knife, endoscopic knife, we resected from its bed, and this is the final image. You can see the muscle fibers in it. It's a submucosal dissection. That's submucosally you dissect all the tumor, and all the margins were free, and major surgery was actually prevented. I don't find any, obese people in the audience, but yes, endoscopy is now a treatment of obesity. So, well, these are all the FDA approved devices. In India especially, we have 2 devices available. One is at B, that's the Orbera, and another is at D, SPATS. SPATS is an adjustable balloon where we fill this balloon endoscopically in the stomach. We inflate it with saline, depending on the age, the amount of weight loss we want to achieve. And it's kept in stomach for a period of 1 year. And we have dramatic results in the weight loss by this thing. Endoscopic therapy is now at one end. It's in the middle. So the one end is the medical therapy. Now we have this tirzepatide and other drugs available in India. Semaglutide and tirzepatide, they are available in India. And on the other hand is the bariatric surgeries, and the middle path is now taken over by this endoscopic sleeve gastrostomy, gastroplasty actually on this corner. It has revolutionized. It's not available at our center yet, but we'll be trying to provide. This is the first intragastric balloon placement in our state. So this lady, she had a BMI of 33. So in last 8 weeks, she has lost around 12 kgs of weight. So around 400 ml of balloon, this saline was used to fill the balloon. And this is the third month of this intragastric balloon. We'll keep it in place for 1 year. When we talk all about these fancy things, so health sir will also agree, all these procedures and all that, they come with risks. They have their procedure related risks. The higher you go in procedures, there is, and especially in this part of the world, acceptance in public as well as patients is always, everybody wants a good result. So I was lucky to working in this unit, and this was one of the one of the landmark papers actually. It was a loop clip closure of acute perforations. So using actually very tools which are they cost very less, some loops and some clips, and you close the perforation there on the table only. So we had presented this work in Copenhagen in 2023, and these are all the devices, just an endoscope which is available already with us. There is a endo loop, it's by a Chinese company, and then hemoclips. So this was a case performed by me. When we talk about being a good endoscopist, one should not shy away from the complications. So this, I was doing an colonoscopy. It's a case from Hyderabad. So it was a large diverticulum. While negotiating the sigmoid band, there was a perforation. You can see the pericolic fat, that yellow thing. It's a fat there. So on the same table, under same propofol sedation, we placed a loop. You can see that blue thread, and a clip is applied. Then we circumferentially apply this loop with the multiple clips, and this is the final result in that corner. All the clips and this loop is pulled, and this is the colonoscopy of this patient 3 months after. So this area, there is some scar left, the clips and loop, they have fallen off. So the patient, doctor gets saved. If we shift her to a surgical unit, first the gastroenterologist will be beaten on the way, and then surgeon probably too, and a major surgery is actually avoided. This is a very this case is very special to me. This gentleman, he was a jeweler from Rajasthan probably. He had large stones, CBD stones. So while performing in ERCP, pulling the scope, there was all air everywhere. And you can see this is the duodenum. We can see the lesser sac through this. And this stone slipped through this perforation into the abdominal cavity. So we retrieved this stone by a basket from the cavity. This is the perforation, that hole. The lumen is there. So now we are going with the same loop. That is the perforation. We don't have this marker. So this is the perforation. So we are applying the clips all around this margins of the perforation. This gentleman, he was a 75-year-old. He had coronary artery disease, and this big perforation in duodenum, it's almost, it's going to be a catastrophe for the patient. But since we were doing an ERCP, he was under sedation. It was a propofol sedation. So, without changing the rooms, without adding to fare and all that, even the patients and the family, they didn't know that a perforation has occurred. Then it was subsequently after a few hours, we explained them there was a perforation, and we have placed so many clips. So then usually what we do is that we do a CT scan, check CT scan after a few hours. Then after 12 hours, oral feeds are started. Usually in duodenal perforations, there will be a Ral's tube in place for around 72 hours, and then the oral feeding is started. This is a case from hospital at Paras. This was right hemicolectomy patient. He developed a large fistula at the anastomotic site. You can see this large fistula. And he had malignancy. He was a smoker, peripheral artery disease. So instead of reopening the patient, so this was the thing. This is a large clip. It's an OTSC clip. I will show you the representational picture of this. So this large picture, it's not from the case, it's a representational picture. So it's this type of a clip, it's a very costly clip actually. So we place it over the opening, and then the perforation gets closed there only. No need of any surgery and all that. Well, these are all the things which are available at our center. Now the world has moved on to robotic endoscopy and the artificial endoscopy. So this is again a study from our center at Hyderabad, where I was working previously. So it was an AI assisted endocytoscopy where you don't take a biopsy. There is a zoom, optical zoom. It's around 760x zoom, and you use specific type of this dye. You spray it over the lesion. It's a polyp, and then you just freeze it. It reads it, and it gives you the result where the polyp is neoplastic or it's non-neoplastic. So this is a Ideas group. It's an Indian and Hong Kong collaboration. So these were the results of the study, and this is mainly what we see. That small polyp, we shift it over to narrowband imaging, then do an endocytoscopy, and this is the final result on the endocytoscopy after staining with methylene blue. So this polyp usually, depending upon the vascular pattern, the mucosal pattern, it reads it out whether it's a malignant, it's a neoplastic, adenomatous, or a benign lesion. Thank you so much for your time.
Thank you so much, sir. It was good to have a tour of our stomach before putting our food in it. So now something about the institution that has made all this possible, the academic extravaganza and the 2 days upcoming medical super specialty camp, Paras Hospital, Srinagar. Paras Hospital, Srinagar, as we all know, is synonymous with excellence and quality healthcare. But I would like to touch upon a topic that it came recently in the media, that some complication happened in Paras Hospital, and an image assassination was done in the social media especially. So in their favor, I'd like to say, if you are dealing with such complex situation, you are bound to have complication. As we all saw, very complex and almost impossible situations are being dealt by them. So if you are dealing with such complex situation, it's part and parcel of our job to have complications. Because some expert surgeon was asked a question that how to have a complication-free career. He said, don't operate at all. If you don't do anything, you don't have any complication. If you are doing such complex situation, you are bound to have a complication. So जैसे एक उर्दू में कपलेट है, गिरते हैं शाहसवार मैदान जंग में, गिरते हैं शाहसवार मैदान जंग में, वो तिफल क्या गिरे जो मैदान में घुटनों के बल चले. तो कुछ करते नहीं है, वो उनका इमेज हमेशा अच्छा रहेगा क्योंकि वो कुछ करते ही नहीं है. ये जो आपको एक लोगों का एक मिलता है क्रिटिसिज्म, दिस इज़ ऑल्सो ए रिफ्लेक्शन ऑफ द गुड वर्क यू आर डूइंग, क्योंकि जो अच्छे लोगों को ही क्रिटिसिज्म झेलना पड़ता है. सो विद दिस आई लाइक टू इनवाइट मिस्टर बिलाल मलिक, Manager Corporate and COP, to give us a virtual tour of Paras Hospital.
So this is, we're going to start. I will not, take more than 5 minutes. As per, these are our 4 brand pillars, where, which is our vision. Like compassion is over there, quality is over there, okay, and affordability plus accessibility. And especially we'll talk about Paras Hospital. You cannot compare this hospital, this level of standard of treatment or hospital as per the other hospitals are available in the Srinagar. You cannot compare this hospital to those hospitals. You can compare these hospitals like Delhi, like Chandigarh, and other metropolitan cities. So this is the front office. This is our emergency, and these are our state-of-art, surgical care, advanced X-ray technology. You ready? I will show you once again. You can see 24/7 emergency. We have consultant-based emergency 24/7. Surgical care, state-of-art, advanced X-ray technology. This is fast and accurate, reliable imaging and timely treatment, CT scan. This is OPD room. This is our general ward, you can just see. I think you guys are going to enjoy it because you are getting the internal views. This is single bedded room. This is our deluxe part, attached with the guest room as well. This is our dual bedded chamber. This is the cafeteria, and thank you so very much. Thank you so much very much for this wonderful evening. Dr. William, please come on the stage. Sorry, I will have to some announcements as well. We're going to have memorandum of understanding with the Bakaria Association. We want, like if the patient is going to refer in Parcel Srinagar, we will give you the extra benefits and the special compliment for those patients, and that will be done written inshallah. Thank you.
Special thanks to President Dr. Ahmad Ali, Vice President Dr. Nasreen, Dr. Uliyat Ali, Field Director, General Secretary Mr. Vilayat Ali, and Chief Organizer Mr. Habibullah. My special thanks to Mr. Ahmad Hussain, Field Supervisor and Transportation in charge. We as Paras appreciate your partnership and look forward to your continuous support in our future endeavors too. Thank you so much.
Care and Research Center Kargil and the general people of Kargil, I would like to express my sincere gratitude and thanks to the team of doctors visiting from Paras Hospital, Dr. Mohammad Maqbool, Dr. Naeem Firdos, Dr. Hilal Ahmed, Dr. Adil Ashraf, and special thanks to Mr. Arun Sharma, Mr. Bilal Malik, and Mr. Iqbal Rahmani sir, who have put a lot of efforts to make this possible and make this event a success. And my team of Bakaria, consultant doctors, senior consultants, medical officers, block medical officers, and other people gathered here. A very heartiest gratitude and thank you to all of you.
Respected speakers, esteemed doctors from various super specialty branches of Paras Health, including our cardiologist, pulmonologist, nephrologist, and gastroenterologist, with their team, including the technical staff led by Mr. Arun Sharma, Mr. Bilal, and Mr. Iqbal Rahmani. I, on behalf of Bakaria Healthcare and Research Center, which is a health wing of Imam Khomeini Memorial Trust, Kargil, extend my heartfelt gratitude for your participation. My gratitude to the distinguished delegates and to the esteemed speakers whose elaborative lectures delivered here made this continued medical education a beautiful evening and a very successful event. I extend my heartfelt gratitude to my doctors from District Hospital Kargil, including the senior consultants from various specialties, my colleague doctors, medical officers, block medical officers from various blocks. Their contribution is also appreciable for supporting me in this during these days. I extend my gratitude to my executive members, my colleague doctors, to my media person, and to the management of this hotel, Highland the Kargil. This CME, conducted in collaboration with Paris Health, is a testament to our shared commitment to continued medical education. I hope this will bring laurel to the general public and especially to the contribution of medical advancement to my colleague doctors here. Lastly, मेरे पास अल्फाज बिल्कुल कम है, चूँकि मैं खुद पारस जाके आया हूँ, वहाँ पे जो मेरा उनके साथ, इनके डायरेक्टर के साथ, actually I expected Dr. Murtaza to visit here, but unfortunately he is not here, missing a lot. उन्होंने मुझे कमिटमेंट किया था कि मैं करगिल आ जाऊँगा, but unfortunately because of his busy schedules. But इकबाल रहमानी हैं और बिलाल हैं जो हर आए दिन रात कॉल करते रहते हैं, और इनका जो कमिटमेंट और जो कंट्रीब्यूशन है, जो सपोर्ट इन्होंने किया है और जो इन्होंने मेहनत की है दिन रात. लास्ट ईयर भी हमने कैंप कराया था, उसमें दैट वाज अ वेरी सक्सेसफुल, इंक्लूडिंग ए CME ऑन न्यूरो सर्जरी एंड न्यूरोलॉजी. तो जो हमारा कैंप रहा था और सर्जिकल न्यूरो सर्जरी का जो कैंप रहा था, दैट वाज ए सक्सेसफुल 3 days event. Probably it was a 3-day event. इकबाल 3 दिन का था वो. तो मैं मिस्टर इकबाल और मिस्टर बिलाल का थैंक्स कहना चाहता हूँ, और ख़ासकर इकबाल का, इसको नींद ही नहीं आता है जब इनको पेशेंट का ये होता है. तो बहुत मेहनत की है इन्होंने, राइट फ्रॉम श्रीनगर वाइल ट्रैवलिंग टू करगिल, द्रास में भी ये रुके, वहाँ पे भी इन्होंने काम किया, और यहाँ पे भी आके 3 दिन इन्होंने काम किया है. तो टू मेक दिस इवेंट बिग सक्सेस, और जो कल का जो हमारे दिन है, आज का ओवरनाइट आप रेस्ट करेंगे सर, फिर मॉर्निंग 8:30 पे वी प्रॉमिस टू हैव ए वेरी हेक्टिक OPD.